It's my distinct pleasure and honor to introduce Steve Green, my friend and mentor. Steve is Associate Clinical Professor and Associate Chief of the Hand Service here at NYU Hospital for Joint Disease and NYU Langone Health. And he's going to talk to us about nerve compression and general principles, and then we're going to get into specifics with each of our other speakers. Steve, if you're ready, we're ready to start.
Thank you, Nader. The aim of my presentation is to provide a foundation for the understanding of the pathophysiology of nerve compression syndromes and the methods of evaluation. Before I go much further, I think it's important for us to spend a bit of time talking about the functional anatomy of the peripheral nerve. I think we're all acquainted with the structure of a peripheral nerve in terms of the epineurium, the perineurium, the endoneurium, and the axons. But one portion of the anatomy which usually doesn't get much attention are the blood vessels which provide nutrition for the peripheral nerve. In addition to vascularity, conduction of electrical impulses requires intact myelin for those large fibers which provide most of our sensibility and motor function. In addition to having intact myelin, the integrity of the axon is critically important for neurological function. It's also very important for us to have a firm understanding of the anatomy of the forearm, wrist, and hand, because nerve compression syndromes predictably occur where nerves pass through fibro-muscular-osseous tunnels. It's also important to understand that these tunnels vary in terms of their volume based upon the position of joints. This little picture you see on the side demonstrates what happens to the cubital tunnel in positions of both extension as well as flexion. And you can see that in the position of flexion, the cubital tunnel actually narrows, which can produce a compression. Also, it's important to understand that nerves glide when they cross joints. If there's fibrotic changes around the nerve which inhibits gliding, this can aggravate or cause a neuropathy. So what are the kinds of effects that compression syndromes produce that we note when patients complain and what we evaluate? And the two things that we critically need to evaluate are the alteration in sensibility and the alteration in strength. As far as the pathophysiology of compression, the amount of compression significantly affects the ability of nerves to conduct electrical impulses. Normally, the pressure within the carpal canal is only 2.5 millimeters. With increased pressure, the ability of these nerve fibers to conduct electrical impulses significantly reduces, and experimentally, when the pressure reaches 60 millimeters, there's complete sensory block. So obviously, the effect of nerve compression is going to be based upon not only the magnitude, but also the duration of compression. The fibers that are mostly affected in nerve compression syndromes are those which are surrounded by myelin. And as you know, myelin helps produce a significant increase in conduction velocity compared to axons which are not surrounded by myelin. So any compression which destroys or damages the myelin is going to significantly affect the ability of the axons to conduct electrical impulses. I think we should separate the effects of compression into two basic categories. One is a neuropraxia. This tends to be a physiological effect on the nerve in terms of its ability to conduct electrical impulses. This is frequently reversible. It is frequently associated with loss of myelin, but what's very important to understand is that the axons are intact. These are patients who present with paresthesias and some weakness. An axonectomesis is a much more serious effect of compression, and in this situation, the axons are actually disrupted. These patients, rather than complaining of paresthesias, have true numbness, and these patients, rather than having weakness, have visible atrophy. I like to separate the symptoms of compression into 3 stages. The earliest stages is episodic paresthesias, which means that the patient may have episodes of the neuropathy, but there are other times when the nerve function is completely normal. An intermediate stage is when the symptoms are sensory, are constant, and they have mild weakness, whereas in the late stage, the patient has constant numbness as well as severe weakness. I think this is a worthwhile checklist that you should use in evaluating patients who have a suspected compression syndrome. Obviously, we need to look at whether or not there are other underlying problems, such as diabetes or arthritis, which may affect nerve function, and sometimes, unfortunately, neuropathies such as diabetes and compression can coexist. As far as physical examination is concerned, I think the first thing we are always taught in medical school is to look. And what we should be looking for is swelling and obvious atrophy, as you see here, of the thenar muscles. Joint mobility needs to be tested because some patients have arthritis, which will significantly affect the mobility of their joints. And sensory and motor function and provocative testing is something I'm not going to talk about. As far as sensibility testing is concerned, I think we need to be somewhat objective. These 2 tests are not purely objective, but I think it's important to record sensibility testing so that when you reevaluate the patient, you can compare whether or not there has been progression or resolution of the problem. 2-point discrimination is most easily performed. However, it's only abnormal when the disease is severe. Sims-Weinstein testing, which tests threshold rather than density, detects much earlier compression, but it takes much more time to perform this, but it is certainly more accurate in determining early compression compared to 2-point discrimination. I think it's critically important to do muscle testing and to grade the muscle based upon this famous English method because, again, we want to determine whether or not there has been progression or resolution of the problem both before and after any form of treatment. There are a number of provocative tests, which I'm sure all my co-speakers will discuss. These provocative tests, I think, are useful for a patient who has episodic symptoms, especially in a situation where the patient presents without symptoms in the examining room, but you can reproduce the symptoms either by percussing over the nerve, which we call a tunnel, or by narrowing the canal, as we're doing here on the right, by putting the wrist into extension and compressing the carpal canal ligament. Electrodiagnostic studies are very useful. They are objective. However, they are not perfect. They tend to be effective in determining whether or not there's slowing of conduction. When we look at these electrodiagnostic studies, I think it's important for all of us to read the studies rather than to just look at the determination made by the person who did the study. We look for slowing of conduction, and we look for reduction in amplitude of response. As far as the EMG portion, this is critical in determining whether or not there's any evidence of axonal loss, where you see evidence of fibrillations or positive sharp waves. In the absence of fibrillations and positive sharp waves, this probably presents as a neuropractic lesion rather than as an axonotomesis. The problem, however, with electrodiagnostic studies is that they're not always accurate in determining what is going on clinically. These are very useful studies, but I think we need to rely on history, physical examination, usually as equal to electrodiagnostic studies. The other problem with electrodiagnostic studies is it really depends upon the skill of the person doing the study, and I would recommend that each of us find someone that we can rely on to do these studies. Otherwise, we get inaccurate findings. To give you some examples of the negative aspects of these studies, there was a study done in the Journal of Hand Surgery of patients who had clinical evidence of median nerve compression syndrome in the forearm, but only 24% of those patients had electrodiagnostic evidence of this problem. In measuring the carpal canal, 10% negative and 10% false positive have been consistently found. Ultrasound has now become a popular way of objectively determining the diameter of the nerve. It does not necessarily determine function of the nerve or the severity of the compression, but it certainly is very accurate in determining the level of compression at whether it's the cubital tunnel or, let's say, the carpal tunnel. MRIs are rarely useful in nerve compression syndromes, but certainly useful if you think that there is a tumor which is causing the problem. So now I'm going to turn the lecture series over to my friends who are going to talk about the typical syndromes affecting both the median, ulnar, and radial nerves. Thank you.